Hi everyone, it's such a pleasure to be here. So today I'll be speaking about gender and health and what it really means to address the failures in medical research and healthcare that means some people are not getting the treatments they need. There we go. And this may feel slightly oblique and tangential to some of the debates you've had about gender and health before, because, as was already mentioned, I've been thinking about this for a very long time, and my thinking on it has evolved over that time. So first, just some background on me. I'm a journalist. I teach science writing at MIT, and right now I'm working on a book about human classification, so how we categorize people, and particularly how institutions and scientists, researchers classify people, and what that actually means, because we hear a lot about the value of data, collecting data, but I think we don't often interrogate enough why we collect that data and what we're actually using it for and whether it really helps people in the end. How do we know that research that's primarily done on young, white, healthy males can be extrapolated to women? So those are the words of Phyllis Greenberger, the president of the Society for Women's Health Research in Washington, D.C., back in 2011. And she had been saying this already since the 1990s. There had been a very big women's health campaign that began that decade to try and get more women included in clinical trials, to get women's health research better funded. And it worked. You know, that decade of campaigning in the 1990s really did work. Funding bodies and journals across the world have since then dramatically stepped up their commitments to including sex and gender as variables in biological research. We hear about the gender health gap much more than we used to. I mean, it's mainstream news now. I'll just tell you this is many years ago, so before any of the staff of Wired were still at Wired UK then, and I brought up issues of sex and gender to the editor at that time at Wired UK, and I was basically told that I should just leave. You know, there was no point in talking about these things, and it's completely different now. You know, right across scientific journals, everything, these are big issues. But it often comes back to this same question: how do we know that women's bodies aren't different from men's bodies? We don't actually have an answer to that question. We have assumptions, but we don't actually know the answer. More than a decade later, we still don't have a conclusive answer, even though we've got so much more data on sex differences. The truth is that research tells us that sex differences do exist in some aspects of health, the most obvious ones like reproductive health, hormone levels, things like that. But in many other cases, what we're seeing from the data, and I should say here that women are very well represented in clinical trials now. In the US, they have been for around 20 years, in the EU for a little bit less, but they are very well represented. We have a good kind of data set. And so we can learn a lot from that data now about sex differences. And what we see in many cases, that what we are noticing is not huge sex differences in responses to drugs or underlying biological conditions. Most of the time, most of the things that are killing men and women are the same reasons, and they're killing them in the same ways. Many of the reasons that we see gender health gaps actually are not down to then sex, they're down to gender. Differences in the way people are treated and thought about and the assumptions we make in society. And so just to give you, I'm going to give you a few examples now. In 2013, and this is often the paradigm example of why we need to think about sex and gender in health. In 2013, the Food and Drug Administration in the US took the very unusual, in fact now unique step of recommending that women should be given a lower dose of Zolpidem. This is an insomnia drug than men, because they were thought to still be affected by it for a longer period than men, so they could still be affected by it in the morning, which was a safety issue. And this was a very rare move, one that's regularly cited by campaigners for women's health research. Often it's stood up as an example of sex difference. In fact, it wasn't, subsequent research has shown that it isn't really sex difference as such that's to play here. Research was done at Tufts University showing that this was more to do, or at least, to a large degree to do with body size, that your body size was determining the rate at which you were clearing this drug, which makes perfect sense. This is why we have different dosages for children and for adults. But what that also means is that a larger woman might need the original dose. right? And a smaller man might need the half dose. So in this case, we are using sex as a proxy for body size because we collect data about sex. We don't tend to collect data about body size in part because it fluctuates, but also if we are using something as a proxy for something else that is an imperfect proxy, why don't we just use that original thing? Why do we not just use body size as a measure for how to decide what kind of dosage somebody should get of this drug? And that's a kind of perverse way that sometimes medicine works, is that you base your diagnostics and your treatments around the data you have rather than the data that you need. Another example that challenges this idea of underlying sex differences is heart attacks. And in fact, I wrote about this in my 2017 book, Inferior, because it was received wisdom at the time that women suffer different heart attack symptoms from men. That was kind of the medical orthodoxy. But a large study in 2019, funded by the British Heart Foundation, carried out at the University of Edinburgh, found that chest pain was the most common symptom for both men and women. So in excess of 90% of cases, chest pain is the most common symptom. And a similar percentage of men and women reported pain that radiated to their left arm. So again, this is a very common recognizable symptom of a heart attack. The problem with underdiagnosis of women, which is real, was instead, at least partly because people, and by that I mean everyone, including women themselves who are having heart attacks, not believing that they were having one because they were women. Because we think of heart attacks as a male condition. This is something that happens to men rather than something that happens to women. So even women who are having heart attacks are slower to call for an ambulance because they don't believe they're having one. And the people around them, including the health professionals, are less likely. So, this is not a sex issue, this is a gender issue. You're having exactly the same symptoms as everybody else, and yet because of your gender, you genuinely don't believe that it's possible for you to have a heart attack. It is gender, the social dimension of how we treat people, that can explain many of the failures when it comes to women's health. It is often about women not being listened to. This is not a sex issue, this is about gender. This is about people in the waiting room, in the doctor's surgery, just not believing someone when they're presenting their symptoms and talking about their pain, being dismissed, not just by male doctors and nurses, but by everyone. And we have to remember the healthcare profession is a very diverse profession. In this country, there are a disproportionate number of ethnic minorities in the NHS. There are very high rates of women working as healthcare professionals all over the world. So this isn't, men as a cohort discriminating against women. This is about we as a society have these ideas. So we need to be careful when it comes to each condition that we're diagnosing the problem where it is and not where we imagine it to be. A good example, another example, is black maternal mortality. We know that black mothers in Britain face around a 3 times higher risk of maternal death than white women. Other minorities also face heightened risks, and we see similar, although not as stark, statistics in the US. Now, I've seen people biologize this, racialize this, talk about black women's bodies needing separate research because non-white bodies are somehow fundamentally different and we don't have enough data on them. That is an incredibly dangerous assumption to be making. Race, as hard as it is to believe, is a social construct. The reason that women are suffering these differential rates is because we are not treating them in the same way. We're not believing people in the same way. And I know this myself because when my mum had breast cancer in this country and I went to the hospital, my friend who is a doctor in the NHS told me, make sure you and your sister go along with her to every single appointment because if they see you speaking good English, she will get a better level of care. So this is a real impact, and it's systemic. It permeates society. It's how we treat each other. And it's in fact this woman, Jenny Joseph, a UK-trained midwife who now works in Florida, who has shown that it's not about underlying biology, of course. It's about care. She's actively improved maternal death rates among non-white women simply by improving the quality of care that they get, maternity care, listening to their concerns, responding when they say they're in pain. We don't always need technological fixes to problems. We don't always need more data. Sometimes we just need very simple things like not allowing our biases and prejudice to get in the way of recognizing when someone is telling us something. It can be so tempting for scientists to look at a gap and want to find a simple biological explanation for it. But when it comes to gender and health, those simple explanations often don't exist. They can't be solved simply with more scientific research or data sometimes. We need to be able to decode what is happening one condition at a time to understand the real processes at work and get to the heart of the reasons why we're seeing the differences that we do. A person's health is intertwined with their social circumstances and their life experience, of which gender forms a part, of course. But gender isn't a fixed quantity. It means different things for different people. And it also changes over your lifespan, the meaning of gender. So, for example, a Canadian study published in 2016 found that patients under the age of 55 and who had been hospitalized with acute coronary syndrome experienced higher rates of recurrence if they performed gender roles more stereotypically associated with women, independent of their actual designated sex or gender. So it didn't matter whether you were a man or a woman. If you were carrying out those typically feminine gender roles at home, you were more likely to experience recurrence of this condition. Those roles included doing relatively more housework, not being the primary earner at home. The one variable that significantly influenced the effect size was anxiety. People who carried out more female social roles were more likely to be anxious. So again, these are mutable variables. These are variables that will necessarily change as gender roles in society change. To assume that they are kind of hardwired into one sex would be a mistake because eventually those parameters will shift. An earlier study in 2009 in Japan found that women living with their spouse and children had more than double the risk of coronary heart disease of women living with a spouse but no children. So you can see the gender health gap then is more complicated than it might seem. And I would argue it's time for medicine altogether to move away from broad, sweeping statements about men's health and women's health and do more to recognize each patient as a complex individual for whom sex and gender plays a part in being that individual. We're rapidly getting the data that allows us to do that, and this is where I think technology is useful, that gender is actually a very blunt tool for understanding human difference. It's useful, for example, in reproductive health. In almost everything else, it is imperfect. You know, we are not in the business of treating groups of people. We treat one patient at a time, right? One individual at a time. We need to understand that individual because knowing the group really can't tell you very much when it comes to treating one person. We can collect information about habits, diet, exposure to stress, the kind of roles you're playing in society, get more information on the social determinants of health, how the way we live and the way we're treated, how that impacts us. And all of that combined, if used responsibly, could help, I think, to build a better picture of individual patients. For a long time, sex and gender and race have been part of the drive of personalized medicine. I would hope that the next generation of personalized medicine gets a bit more sophisticated than that. Thank you.